Hello guys, welcome to our channel. Today we will be discussing of the obstetrics rapid revision. Today we will be discussing of the most of the important obstetric topics, and tomorrow we will be discussing of the gynecology. So OB-GYN will be in the two parts. If you want to avail these notes, please do join the Telegram group and text me from the Telegram group. And those who are new to this channel, please do subscribe and share with your friends, and also please do watch the other videos also because it will be helpful for you in the examination. So let's start the discussion without the delay guys. So here you can see this is a Dr. Anandi Bai. So I think most of the students will be knowing this. She is the first doctors to graduate from the America. Even though she is a physician, I just wanted to include in the obstetrics because her first thesis she submitted, it was still in the Pennsylvania University. So she has written that how the gynecologist and the obstetrics from the Aryan civilization has impacted the Indian civilization. So she is the first graduate from the American MG degree, and she is a physician who is graduated, right? So let's start the discussion, guys. So first and foremost, we will be discussing about the important parts, how the spermatogenesis and the oogonium, all this will be happening. So first we'll be starting with the spermatogenesis. So spermatogenesis from the male, the spermatogenesis, how it is going to start? It is going to start from the gonadal cells, right? So from the gonadal cells, it is going to give rise to the spermatogonium. And spermatogonium will gives us the most important one. This is the primary spermatocytes, and until here we are having the 46 only. So from the spermatocytes it is going to give rise to the secondary spermatocytes, and here this is the first meiosis one, and here you are going to get the n number, only 23 number which will be getting, and from here we are going to get the spermiogenesis and the sperms will be formed. Okay, so this event is the spermiogenesis. And how about this event? This is the event where it is a spermatogenesis. Spermatogenesis. So how many days it will take? On average, it will be taking around 72 days to form. Okay, it will be taking of the 72 days. And where this spermatogenesis is forming at the seminiferous tubules. Okay, it will be happening at the seminiferous tubules. And how it is going to be mature and motile. So motility and the maturity. So this both will be happening in the epididymitis. This will be happening in the epididymitis, right? So this is the overall important points about the spermatogenesis. And a sperm, how many days it will be viable? So generally the sperm viability is 72 hours. Okay, this will be around 72 hours. So that's why whenever there is an emergency contraceptive, we recommend that within the 72 hours the patient should be getting this emergency pill, because the sperm has a viability life of the 72 hours. Okay, don't confuse with the 72 days. 72 days is to form the sperm, 72 hours is the viability of the sperm. All right, next, moving on to the oogenesis. Okay, oogenesis. So oogenesis and the spermatogenesis differences is, it is happening at the puberty. It is happening at the puberty, but oogenesis is already started in the intrauterine life. It is started already in the intrauterine life. By the time they have in oogenesis, the gonads, these gonads is going to have almost 7 million. 7 million of the ova that is present in the intrauterine life. By the time they get the puberty, it will be decreased to the 1 million, and by the time of the ovulation, for the first ovulation, it will be around 5 lakhs. So it will be gradually decreased. So that is what happens in the oogenesis, and it is going to produce the oogonium, and this oogonium is going to produce the primary oocyte. But this primary oocyte is arrested, right? And when it is going to open, it is going to open at the time of the ovulation. The arrest will be revealed at the time of the ovulation. So arrest is happened in the intrauterine life, ovulation is happened at the puberty, right? And then if the ovulation is done, intrauterine life, arrest is already relieved, what happens? It is going to produce the secondary oocyte, and also it is going to produce the new polar body. It is going to produce the polar body, right? And secondary oocyte is also going to arrest. And when it is going to relieve, it is going to relieve at the time of the fertilization. When the sperm mates, it is going to relieved. Okay, so what are these events? What are the arrest that is happened? So the arrest is happened at the time of the metaphase. Sorry, this is at the diplotin phase. This is at the diplotin stage of the prophase 1. And the second arrest is happened at the metaphase, at the prophase 2. Right? So this is the first arrest and the second arrest that is happened in the female. So how many hours this is viable? This is viable around 24 hours only to get the sperm attached and the fertilization is happening in this patients. Right? These are the two important points that you have to remember. Next, followed by when the both the sperm and the ova is met. So this is the event that we are going to have the fertilization. And what is the date of the fertilization? Exactly on the day 14, the fertilization is going to take place. And what is the most common location? The most common location is the ampulla of the fallopian tube. Ampulla of the fallopian tube. But how the sperm is going to come with the attachment of the ova? So the sperm has to go through the capacitation, right? Sperm has to go through the capacitation. In the capacitation process, sperm will become the hypermotile. So this point has been also asked. Hypermotile. And hypermotile, where it is going to have? It is going to have in the tube, the fallopian tube. It is going to get the hypermotile, and this is around 6 hours it will take place, right? 6 hours it will be take place. And when this is formed, the sperm and the ova is attached, it is going to form the zygote, right? It is going to form the zygote. So this is the general process of the fertilization. And here there is a question that is asked here: what is the zona reaction? What is the zona reaction? So the zona reaction is a zona pellucida that covers the entire sperm, sorry, entire ova, and it will prevent the polyospermy. It will only enter one sperm. It will prevent the polyospermy. So that is one important point that you have to remember. That is a zona reaction. All right. So next, moving on to the another important points, how we are going to diagnose these patients. Whenever there is a patient who is with a pregnancy, how we have to see? So the patient will be telling us there will be last menstrual period, that is a mention, and this is the most important point. Now the patient is having presented with the amenorrhea. Patient is presented with the amenorrhea. So this is the basic sign the patient will be explaining us. Next, after that we are going to ask the patient about their history, and here how we are going to calculate the obstetric score. Obstetric score. And remember, the obstetric score is most important, guys. First we will be inquiring about the patient gravida status, and then we will be expecting the patient about the parity. And what is a gravity? Gravity is number of pregnancies. How many times the patient is pregnancy, and how about the patient is current pregnancy. So it will include the past pregnancy, and also it will include the present pregnancy. And parity. How about parity? Parity is only calculated the all the pregnancies that the patient is had. Does she reach the 28 weeks or not? If ever it is not reached the 28 weeks, we will be not considering the parity. Okay, so that is what parity we are going to calculate. And along with that, we also have the other one. This is for the term, and other one we will be having the T pulse score, that is P for preterm, how many preterm history, and A for abortion, and L for leaving. And gravida, number of the pregnancy. For example, let's say that the mother is having the twin pregnancy, two or triplets. What we have to consider, this is considered as a one pregnancy only. But here in the leaving, you can consider as a twins as a 1 and 2. But in the gravida, it is only considered as a 1. Right? Here we will be done with that. Next, followed by will be also expecting the patients to get to understand about the EDD. Right? So what is this EDD? So estimated date of the patient is going to get the delivery. So there is a famous rule that you can follow, that is the Niggles formula. So what is the Niggles formula? So for example, let's say that the patient is having the March 1st 2026. She had the last LMP. Okay, so this is the last LMP. So we have to add plus 9 months plus 9 months plus 7 days to the date, and automatically you will be getting the 1 year plus only. So how much it will be? So 3 plus 9, it is going to be in the December. and 1 plus 7, it is going to be 8th. So 8th December 2026 is the patient expected date of the EDT. But the Niggles formula has the flaws. The limitation of the Niggles formula is it is going to calculate only the 28 days fixed cycle. What if the patient is 25 days? What if the patient is 32 days? How we are going to calculate this patient? So if the patient is having the 32 days cycle, so we are going to expect the patient to minus the score, or we can expect the patient to add the score. So this is a confusion. So sometimes we will be confusing in the examination how to calculate this T-PAL score. So please avoid that mistake, guys, because this can be asked as a simple question and we should not be making that mistake. So whenever the patient is having that 25 days cycle, what you have to do in the 25 days cycle, you have to minus 3 days. Okay, you have to minus 3 days. And if you see that 32 days cycle, you have to add the 4 days. You have to add the 4 days. So that is how we are going to calculate. So 25 days minus 3 days, 32 days, add 4 days. Right? So this is how we are going to calculate the Niggles formula. Let's see some of the signs. So first, in the examination, we are going to check the abdominal examination. So abdominal examination, we are going to check the patient how the uterus is growing as the baby growth is also happening. For example, at the time of the 12 weeks, the fundus will be just above the pubic bone. So for example, this is the pubic bone. It is just above the pubic bone at the time of the 12 weeks that we are going to see, right? And how much time it will reach the umbilicus. Here the umbilicus on estimation, exactly in the examination you mark this as a 22 weeks. This should be marked as a 22 weeks at the level of the umbilicus, right? Next, by the time of the term, it is going to be reaching the 36 to 38 weeks, and it is just under the Xiphis sternum. Okay, this is the Xiphis sternum, right? This is the Xiphis sternum part. So where the fundus will be reaching its highest point. And after the 40 weeks, what happens? The pelvis will be both the pelvis will be having the process of the labor will be start. So the head will be descending downwards. So the uterus will also coming downwards. So after the 40 weeks, that will be started to drop. Okay, every point will be started to drop. So that is what happens in the abdominal patients. And how about immediately after the delivery? So for example, the baby is already delivered. So the baby is already delivered. What happened at this point? So it will come just below the umbilicus, just below the umbilicus. And after the day 2, on the day 2 of the postpartum, day 2 of the postpartum, so the height of the uterus will decrease the 1 breath per day. It will be decreasing of the 1 breath per day. So this is how it is decreasing per day. This is how we have to calculate of the patient with the abdominal circumferences, right? Next, there will be some of the probable signs, there will be some of the presumptive signs. Okay, as I said, this is the presumptive sign. One of the patient is telling that she is having the amenorrhea. So this is the presumptive sign that the patient is explained us. And some of the other signs, the patient is feeling of the quickening, the patient is feeling of the nausea, vomiting, the patient is feeling the fatigue. All the signs that the patient is feeling, those are considered as a presumptive signs. Next, what are the probable signs? So the probable signs, this is a recent INICT question. Probable signs that is present is respectively, this is what we feel in the patients. Okay, so this is what doctor or the examiner is going to explain to the patients what are these signs. And here the picture that you can see, this image based question is asked in our Fmge exam only. So this is seen at the 8 weeks. This is seen in the 8 weeks. If you can observe, so this is looks like a bluish discharge that is coming from the cervix. Bluish discharge is coming from the cervix, and not just the cervix, it is going to present in the fornices of the 4 lateral walls of the vagina. And this sign is known as a Chadwick sign. This sign is known as a Chadwick sign, and exactly it is seen in the 8 weeks. And other signs that we have is the Hagar sign. Okay, so we also have the Hagar sign, and we also have the Palmar sign. We have the Palmar sign and Osiander sign, and also quickening. So quickening is a probable, not it is a probable, it is a presumptive sign that the mother is going to feel the first fetal movement of the baby. So Hagar sign, here you can see this is also image based question. We are going to palpate the abdomen with the two hands, here the abdomen and inside the vagina. So if you feel this softening of the isthmus, that is known as a Hagar sign. Okay, so bilaterally you are using the two hands to palpate the uterus. So this is happened at the 6 weeks. This will be also present in the 6 weeks. 6 weeks. Next, Palmar sign. What is mean by the Palmar sign? Palmar sign is the contractions. You are able to feel the contractions in vagina. You will be able to feel the contractions in the vagina, and this is heard in the abdomen only. And Osiander sign is a pulsation in the vagina. Pulsation in the vagina. So the Palmar sign is also around the 6 weeks. Okay, 6 to 8 weeks. And Osiander sign is 8 weeks. Osiander sign is also 8 weeks, and quickening, which will be around 18 weeks. So this is how we are going to see the different types of the probable signs which will be seen. And another picture that you can see, this is the Goodell sign. This is the Goodell sign. So what is the Goodell sign? Goodell sign is the cervix. Cervix contains, right? So this cervix is going to feel as a softening on the vaginal examination. So this is also around 6 weeks we are going to see. These are all are the probable signs that we are going to expect in the patients of the pregnant, right? Next, moving on to the Leopard's maneuver. So this is the maneuvers that we are going to perform in the patients who are pregnant, whether it's the first trimester, second trimesters, and we have to perform. So there are the different types of the maneuvers. So this is the first maneuver. Other name for this first maneuver is the fundal grip. This is for the fundal grip. And the second maneuver, if you can observe, the patient is examining on the lateral sides of the patient abdomen. So this is lateral type, or we can also call this as a umbilical type. This is also known as a umbilical type. Next, third one is looking at the Pauli grip. So the patient is like holding the head of the baby. So this is known as a Paulic grip. And the D is the fourth one, and this is known as a pelvic grip. This is known as a pelvic grip. And if you can observe, all the hands in the first, second, and third is looking at the mother side. So we are looking at the mother side only while examining. But in the fourth side, the hands are looking towards the downside. So the examiner of the fourth maneuver is looking at the legs of the patient. So this is question also has been asked. By the way, what we are checking in this all the Leopard's maneuver. This question has been also asked in the examination. So in the first maneuver, that is A, we are checking at the patient lie. So how the patient lie and how the baby presentation has been seen. The fetus presentation is seen. For example, if you feel the butt of the baby, and it is going to be soft, okay, and irregular. How about head? If you feel the head, this is a cephalic position, right? In the head, it will be ballotable. Okay, ballotable. You're going to feel. And coming to the B, okay, coming to the B, in the B, you are looking at the smooth, regular surfaces, right? This is going to be feel as a smooth and regular. And why it is important? Because we can hear the fetal heart sounds. Fetal heart rate can be best heard in the second maneuver. Next, number C. So for the C, this is the Pauli grip. Why we are looking at the Pauli grip? Engagement of the baby, or the engagement of the fetus that we wanted to look. And the fourth one, that is a D, that is the pelvic grip, and this is going to check about the deep pelvis and attitude of the baby, attitude of the fetus that we are looking at. So these are the points that we have to take note when we are taking the Leopard's maneuver in the consideration, right? Next, so what are the changes that is associated with the hormonal changes? We have the hormone that is plays the major role, progesterone, and also we have the hormone that is the estrogen in the pregnancy, estrogen and the progesterone. Let's see one by one point how these hormones are going to make the changes in the pregnancy. So the first and foremost important, P for progesterone, P for pregnancy. So this is a very important hormone that is important throughout the pregnancy, right? And it will be helpful for the smooth muscle relaxation. It will be helpful for the smooth muscle relaxation. So that is what the myometrium does not want to contract. That's why we have the progesterone. So if the myometrium contracts, we can expel the products. So that's why this is going to helpful in the releasing of the relaxin hormone from the progesterone. And next one, it is going to prevent the preterm prevent the preterm and decrease the peripheral vascular resistance. It will be decreasing the peripheral vascular resistance. Coming to the estrogen, estrogen is not released during the pregnancy, but we have the specific thing that is from the fetus. So fetus androgens is going to release the DHEAS. This has been released from the fetus and the estrogen in the mother will be increased. And this estrogen, the most specific is the E3. This is the specific one we produce. But E2 is the most common we see in the blood of the mother. And what are the importance of the estrogen? Estrogen can increase the thyroid binding globulins. It will be increased, and also it will be increasing of the oxytocin during the contractions, and the skin changes such as chalazonia, as the skin changes can be seen in this patient, or the cholestasis, the jaundice can be seen in these patients, and also spider angiomas which will be seen in the patients. So these are the breast changes and uterus changes. All this will be changes that is associated with the estrogen of the patient. Next, some of the physiological changes that you have to understand. How the blood changes will be seen. So basically how the blood changes will be seen in these patients. So the blood changes, the blood volume will be increased. The blood volume will be increased. So this will cause the hemodilution, and hematocrit will be decreased, and RBC mass is increased. So as the total packed cell volume will be increased in this patient. Sorry, this is the MCV. MCV will be increased and PCV will be decreased. PCV will be decreased. So this is the overall blood will be seen. And how about the globulins? So the globulins will be increased, whereas albumins will be decreased. Albumins will be decreased in these patients. So the globulins increase, albumins will be increased. So if you compare the both ratio, 1+1 ratio that we are going to see in our body. And factors, coming to the coagulation factors, all will be increased except, okay, this except questions are important. As we said, 11th and 13th will be decreased. 11th and 13th will be decreased. And coming to the patient's eosinophils, this will be decreased. And how about the neutrophils? Neutrophils will be increased. Neutrophils will be increased. ESR, CRP, these are the inflammatory markers. This will be also increased in this patient, and which does not change throughout the pregnancy. Clotting time and the bleeding time is not going to change. It stay the normal before the pregnancy, after the pregnancy, during the pregnancy, unless or until the patient faces the any coagulation disorder. And this why we also tell that due to the hypercoagulability states, because of the factors include, this phase is also known as a benign uh, thrombocytosis, condition that we see. But there is no problem with this benign thrombocytosis of the patient, right? Next, another important system that you have to take note is the cardiovascular system. So the patient with the cardiovascular system, how it is going to be presented. So generally in the patients of the cardiovascular system, even us also, we will be hearing of the S1 and the S2. And if you heard the S1 split in the pregnancy, this is normal. And even if you heard the S3, this is also normal. And coming to the murmur, so there is a early systolic murmur. Most of the times this early systolic mild murmur is normal in the patients, okay, and cardiac output is increased, so as the stroke volume is increased, peripheral vascular resistance is decreased, and so as the systolic blood pressure and the diastolic blood pressure is decreased in these patients. So that's why if the patient is more progressed to the AOG, we will be considering whether the BP is increased or not. So it has to be decreased as a physiologically. If it If it is increasing, that is the abnormality we are going to find in this patients, right? So systolic blood pressure will be decreasing, so as the diastolic blood pressure is also decreasing in this patient. And you are going to see the left axis deviation in the pregnancy. Left axis deviation, this left axis deviation is also normal because uterus is growing, it is pushing outward and upward. It is going to push, for example, this is the heart, right? It is going to push outward and upward of the heart. That is why we are going to see the left axis deviation. So these are the some points that you have to remember. CVS changes. Next, this is the commonly asking question, guys, should not be ignored. This is the respiratory. Even in the recent INICT question is also it is asked. So how the respiratory changes will be seen in these patients? Okay, so the respiratory changes of the pregnancy, the most of the times we will be seeing the patient is having the uterus upward. So sometimes what happens, this uterus is pushing, right? Diaphragm is pushed, and also so as the surrounding structures will be pushed. So the patient will be having the severe changes. Sometimes the patient can also have the distress due to the growing uterus, right? So remember like this, 2, 4 and the 6, 2, 4, 6 and IRV and ITM. So what are these changes? Let's see. 2 centimeters. This is the 2 centimeters transverse diameter. 2 centimeters of the transverse diameter of the diaphragm. Okay, so this total chest is going to increase the transverse diameter by 2 centimeters, and here the 4 centimeters, this 4 centimeters is upward pushed due to the uterus growing of the diaphragm is pushed more than 4 centimeters or equal to 4 centimeters. Next, this is the 6 centimeters. 6 centimeters is total chest circumferences. This is for the total chest circumferences, right? Next, coming to the ITM. ITM means this is the inspiratory capacity is going to stay normal only, and this is a tidal volume. This is the tidal volume. This is also going to stay normal, and we have the minute ventilation. This minute ventilation is also normal. IRV nothing but it is an inspiratory reserve volume. This is going to stay normal, and the residual, this is the respiratory rate. This is the respiratory rate, it is also going to normal, and the vital capacity, so the vital capacity is going to stay normal. So there is a correction here, please take note that. So IRV, so inspiratory reserve volume, respiratory rate, vital capacity stay normal, but the inspiratory capacity, only the inspiratory capacity, this will be increasing. Tidal volume is increasing, minute ventilation is increasing. Remaining all the parameters of the respiratory will be decreased. Okay, so just the correct, guys, I just mistakenly written that it is going to normal. So IRV is going to stay normal, and the remaining parameters which will be increasing, the inspiratory capacity, tidal volume and the minute ventilation. Okay, next, coming to the renal changes. Okay, coming to the renal changes. In the patients of the renal changes, there is a increased renal blood flow, so as increased glomerular filtration, and that's why there is a decreased urea, decreased uric acid excretion will be decreased in this patient, and as a physiologically there will be glucosuria. So there is a physiological glucosuria is seen in this patient, and due to the some changes of all these parameters, what happens to the patients? Most of the times the patient can present with the edema, and this edema is a pitting edema, and it is also physiological. By the time the patient have the rest, it will be subsided. So physiological edema is also seen in this patient. So these parameters, these different structures, hormones, all this will be considered as a important points for our examination, right? Next, moving on to the placenta. So some of the points that we have to see about the placenta. So let's learn about the placenta. So placenta is formed to helpful to increase the chances, we have to maintain the oxygen and the carbon dioxide. This is the first and motive that has to be maintained between the mother and the baby, right? And what is the shape of the placenta? It is in the discoid shape. It is going to stay in the discoid shape, and the maternal side is going to be 1/6, and in the fetal it is going to be 5/6 position. Almost it is going to occupy. That is the fetal side. And what are the arteries, that the veins we have? We have the two arteries which carries the deoxygenated blood, and one vein which carries the oxygenated blood, which carries the oxygenated blood. And how much is it is going to have? It is going to have the 500 grams. And how much percentage of the blood will be carrying? It is percentage of the 10% of the cardiac output. That means almost 750 ml from the cardiac output it is going to carry to the baby. And they are abnormalities. Battle door insertion means generally if there is a placenta, for example, let's say this is the placenta and there is connection between these arteries, that is exactly at the middle point, but in the battle door it is in the corner. So this is a defect of the battle door. Circumvallate, if you can observe, this is the fetal side, this is the maternal side. What we discussed, the maternal side is very thin, but if you can observe here, the maternal side is thick, right? The maternal side is thick. So that is what present in the circumvallate. And next, bipartite bilobed. Bilobed means two lobes that is equal in size. And succintorate lobe, it is going to be in the small size, and this is the extra lobe. If this extra lobe inside it is going to be retracted backside, so it can cause the PPH and the APH in the patients. And velamentous insertion, it has to insert here in the middle with the placenta, but it is inserted in the chorion and the other structures it is inserted. Circummarginate, it is very thin type of the placenta covering that we are going to see. And the question that is asked, image based question can be asked in this patient. So the image based question is how you are going to differentiate between the maternal side and the fetal side. So this is the maternal side. So maternal side is known as a decidua side. The name of it is decidua basalis. And this is the fetal side. There is a covering and it is going to look like a bluish gray color. It is going to look like a bluish grayish color, and this is known as a chorion frondosum. This is known as a chorion frondosum, and this is the vessels covered by Wharton jelly. This is covered by the Wharton jelly. And how we are going to differentiate whether it is a maternal blood or the fetal blood, whether it is a maternal blood or the fetal blood. So we are going to use the test that is the single alkali test. Single alkali test, because the fetal blood is resistant to alkali, resistant to acids or the alkali. So only if there is a reaction with the this test, that could be the mother's blood only. And what are the things that is going to cross here? So warfarin can cause, okay, so as so many infections, especially the torch infections can cross, IgG can cross, right? IgG can cross, and also such as patient who is suffering from the high glucose can also cross this, can damage this condition. And which does not cross? Which does not cross? Remember, insulin is not going to cross. Insulin is not going to cross. So as heparin, that's why heparin is preferred in this patient, and the IgM is not going to cross. These are not going to cross. And what are the hormones that is produced? It is going to produce the HPL, which will increase the insulin resistance, and it is going to produce the progesterone. It is going to produce the progesterone and the HCG. Okay, all these hormones will be produced by the placenta. These points that you have to remember. Next, moving on to the oligohydramnios. We have here, this is the oligohydramnios. So what is mean by the oligohydramnios and the polyhydramnios? So the oligohydramnios and the polyhydramnios is about the amniotic fluid. How much amniotic fluid that the generally the growing baby will be consisting of. This is the amniotic fluid, how much is consisting, is presented. So normally we have the production of the amniotic fluid which will be started less than 12 weeks only. It is going to start at less than 12 weeks to 20 weeks. Okay, less than 12 weeks to 20 weeks. And here most of the times it is coming from the fetal skin, from the surface of the evaporation of the fetal skin. And more than 20 weeks, it is going to be fetal urine. From the kidneys function, it is going to be fetal urine. Baby will swallow and baby will pee that only. That is a fetal urine that is going to get. And normally we have to check in the four quadrants. We have to check the four quadrants of the amniotic fluid has to be checked. And how much it is going, it should be more than or equal to 5 to 25 centimeters. And if you check the single point, if you check the single pocket, that has to be at least 2 to 8 centimeters. That has to be 2 to 8 centimeters. What is the normal color? What is the normal color? It is going to be straw color that you are going to observe. And if ever the baby is having any problem, for example, the baby is suffering from the Rh positive, Rh negative pregnancy, here you are going to see the golden color. It is going to see in the golden color. And brown color, this is the intrauterine death. This is seen in the intrauterine death. And dark red color, this is seen in the abruptio. In the patients of the abruptio, you are going to see. And coming to the green is like an infection seen with the listeria, and also fetal distress and chorioamniotis. Chorioamniotis. This is also you are going to see. And in the chorioamniotis, you are also going to see the foul smell. This is going to be in the foul smell also. And in the post-term babies, it is the saffron color. Post-term babies, it is the saffron color. And by the time of the 30 weeks, on average, it is going to be 1000 ml. And by the time of the 40 weeks, it is going to be 200 ml. So after the post-term, it is started to decrease. So this is the general information that you have to take note about the amniotic fluid. Next, let's see the defects, how the patients will be presented. So the patients with the oligohydramnios, we will be saying that if it is a less than 5 centimeters. Polyhydramnios, if it is a more than 25 centimeters, if it is a more than 25 centimeters. Let's see the differences. Let's understand what are the causes could be from the oligohydramnios. The most common cause is the idiopathic. We don't know. This is the idiopathic conditions, right? These are the idiopathic most common causes. But oligohydramnios, what I said here, it is most commonly urine. So obviously the baby must be having the renal problems, renal abnormalities must be, okay, or the baby is having any drugs, ACE inhibitors mother is taking, these ACE inhibitors is crossing the placenta, is causing the teratogenicity to the renal abnormality, right? Or the mother is taking the endomethacins, painkillers, this can also cause this renal abnormality. Or mother is post-term, because it is obviously decreased by the post-term babies, or baby is IUGR, or twins, that is also one condition. Next, polyhydramnios, baby is producing more and more, so this is could be GI anomalies. This is the cause of GI anomalies, because unable to swallow, it is still in the womb only. Esophageal atresia, duodenal atresia, abnormalities of the abdominal wall, or the patient is having the neural tube defects, baby can't swallow again, baby is having the twin syndrome, mother is having the diabetes mellitus because glucose will take more and more water, or the mother is suffering from the Rh negative because it can cause the anemia, anemia can cause the fluid over accumulation. All this will be seen in these patients, right? So this is how the polyhydramnios and the oligohydramnios patients will be seen. And the complications, so the complications which will be associated with the oligohydramnios is more severe. It can cause the amniotic band syndrome. It is going to compress this, and the patient can have the hypoplasia of the lungs. Hypoplasia of the lungs. This is the most common. And also cord compression. Cord compression. And if you see this mother more than 32 weeks with this complication, you have to do the termination of the pregnancy. Okay, so the termination of the pregnancy has to be done if any complications that is presented for this patient. Polyhydramnios we can save as much as we can, but until if the mother is having any distress, we can go for the termination, or we can also go to take the amniocentesis. More and more fluid can be extracted outside, right? These points that has to be taken note. Next, coming to the how many antenatal visits has to be done. So generally the maximum antenatal visits is 12. Okay, that has to be 12 visits. According to the WHO, it is 8. According to India guidelines, it is minimum 4. 4 has to be done by the India. WHO is telling that at least 8. And what are the things that the mother has to be taken? So in the first pregnancy, in the first visit only, the mother has to get the TD vaccine. First visit, and followed by that after 4 weeks she has to get the second vaccine. Two vaccines has to be taken of the TD, and if our mother is less than 3 years, she can get one booster. She can get the one booster, that is TD vaccination that we are going to give. And coming to the supplementation, what are the supplementations that we are going to give for this mother? First and foremost important, that is the folic acid. Okay, folic acid has to be given for the mother, and generally if ever they wanted to conceive 1 month before and 3 months after, we have to give this folic acid. How much is the dosage? 400 micrograms. But if the mother is having the NTD, neural tube defect history, or the patient is on the valproates, anti-epileptic agents, for these patients what we have to do, they has to be started 3 months before, 3 months before, and 3 months after, 3 months after. And how much we have to give? Here we have to give 4 mg per day, 4 mg per day. And for the patient of the folic acid deficiency, we have to give same 500 micrograms. Sickle cell anemia patients, 5 mg that has to be given. So this is the folic acid supplementation. Next, coming to the calcium, we have to give 1000 micrograms, and from the iodine it is 250 micrograms. These are 250 micrograms that we have to give for this patient. And for the calories, at least 350 per calories in all the trimesters T1, T2, T3. Average 350 kilocalories that we have to increase for this patient. And iron folic acid supplementation, at least 180 days of the pregnancy and plus 180 days of the lactation period that we have to give for the mother. So these are the basic supplementations that we are going to give for this patient. Next, some of the ultrasound points that you have to remember. All right, some of the ultrasound points that has to be remembered. So in the ultrasounds, how we are going to rely? Basically, we say we are going to rely on the mother's LMP only. For example, mother does not know the LMP. She does not know the LMP. So how can we rely? So we have to rely on the CRL. CRL is the best estimation. CRL will be the best estimation to check the what is the date of the baby. Okay. Next, we are going to do the NT scan. NT scan is to differentiate whether the patient is having the anomalies or not, and this is best done at the 10 to 12 weeks. This is best done at the 10 to 12 weeks. And the second scan, okay, this is the anomaly scan. The name itself, it is a anomaly scan, or we call this as a TIFA scan. This is done around the 18 to 20 weeks. This is done around the 18 to 20 weeks. And then we go for the growth scan. This is done at the 32 weeks. Okay, and the fetal echo, if needed, we have to take around the 20 to 24 weeks. And placenta position, this is done at the 32 weeks and 36 weeks. Both times we have to check. So this is the some of the scans that is important, frequently asked in the examination, right? These are the just basics of the antenatal only. Now we are moving on to the patients with the conditions who is associated with the labor abnormalities. All right, so they are the four types of the pelvises that we have. Okay, one is the gynecoid, platypoid, android, and the anthropoid. Okay, so what are the big important points that you have to take note? Gynecoid is most common overall. This is the most common overall, right? And mostly this will be consisting of the females. And this area, if you can observe, this is in the circular. This is in the circular shape. And here the diameter, the both the diameters, the transverse diameter. This is the transverse diameter. This is the AP diameter. So the transverse diameter is more than the AP diameter. So what is the best that is associated here? So the cephalic position and the normal vaginal delivery is absolutely fine in the patients of the gynecoid, right? Next, here this is a platypod. Platypod is in the shape of the inversely triangle, and these patients is very rarely seen. And here also the transverse diameter is more than the AP diameter, and AP diameter is too much shrunken. So if there is a presentation, the only presentation that is presented here is the face, and the face we can't deliver, and we have to go for the cesarean section. Okay, next, coming to the android. Android is in the shape of the heart. Android is in the shape of the heart, and this is most commonly present in the male patients. All the male patients, it will be consisting of the android type. Same as the females also, android type is seen. And if you can observe these spinal processes, okay, ischial processes very prominent. This is very prominently seen, and presentation it is associated here is the occipito-posterior. There is a occipito-posterior position will be seen in this patient, and here also the transverse diameter is more than the AP diameter, and mostly these patients will land into the CPD. That means cephalopelvic disassociation. Okay, disproportion. The patient can't be delivered. Next, last but not the least, this is the anthropoid. Okay, this is a persistent labor abnormality we see in the patients very rarely, and this is the only pelvis. If you can see, the AP diameter is more than the transverse diameter, right? AP diameter is more than the transverse diameter. If ever the patient is presented here also, we are going to proceed for the cesarean section for this patient, right? These are the pelvic points that you have to remember. Next, let's see the different presentations here. This is the vertex. You are looking at the vertex, that means the head of the baby, and this is the brow. This is the brow presentation. Eyebrows is touched on the examination, and the face. This is completely extended of the patient, right? This is the completely extended of the baby. And in this, most common is vertex. The most common will be vertex. The head is in the flexed position. Head is in the flexed position. Brow position is, this is the partial extension, and the face presentation is hyper extended. This is the hyper extension. This is a hyper extension. And how we are going to treat this patient? Vertex is easy. We can go for the vaginal delivery. And the partial extension, the brow is always go for the cesarean section only, right? Next, fully extension face is also most of the times we will be proceeding for the LSCS, but there is a catch. If the baby is presented as a mento anterior, mento anterior means this one, that is the mentum. If it is a mento anterior towards the pelvis, then we can try for the vaginal, and remaining all we can go for the LSCS of this patient. Okay, these are the criteria that we have to follow. Next, pelvis. Coming to the pelvis and their diameters, that is asked. So we have the three diameters. One is the inlet, and other one is the outlet and the cavity. Okay, so we have to differentiate inlet, outlet and also the cavity. Let's see what are the important parameters and the measurements that you have to remember. First, inlet, then we have the cavity, and then we have the outlet. This is going to decide us whether the baby can have the normal delivery or the baby has to go through the cesarean section. So inlet is tell us about the true conjugate, which is 11 centimeters. It is going to tell us about the 11 centimeters. Obstructed conjugate. This is the obstructive conjugate. It is 10.5 centimeters. Diagonal conjugate. This is the 12 centimeters. Diagonal conjugate is the 12 centimeters. If you can observe here, these are the parameters that we are going to see, right? True conjugate, and also, so here you can see true conjugate from the sacral promontory to the pubic symphysis. This is the true conjugate. And the diagonal conjugate, same. This is the downside of the pubic symphysis. And obstetric conjugate, we are going to look at here obstetric conjugate between these, which will be landing around the 10.5 centimeters we are going to see, right? Next, moving on to the cavity. Cavity have the two different. One is the greater pelvic dimension, greater pelvic dimension. This is around 12 centimeters, and the least pelvic dimension, this is around 11 to 12.5 centimeters. Okay, and also we have the transverse. This is around 10 centimeters, which is the only smallest of all the parameters. Here you can see this is the transverse. Okay, and we also have the least dimension and the highest greatest dimension. Same point we are going to look at the sacral promontory and the pubic symphysis. Next, last one, that is a outlet anterior posterior is a 13 centimeters, transverse diameter it is 11 centimeters. Okay, anterior posterior is a 13 centimeters, outlet is the transverse diameter is a posterior that is the 11 centimeters. Next, here you can see this is the different types of the presentation that the baby can have. Okay, so the baby can, if it is, this is the anterior and the back side of the sacrum is the posterior, we consider. Okay, anterior and the posterior we are going to consider. So right side, the baby is looking at the right side, so this is the right occiput anterior position. Next, baby head, where it is located. Again, it is on the right side occiput. This is the occiput, the presenting part, and the transverse of the side. Okay. Next, right occiput, the baby back is on the posterior side. This is the posterior. Next, left side that the baby is lying. This is the left occiput. Again, presenting part is the left anterior. So this is how we are going to differentiate about the different types of the presentations of the baby. Next, this is the partogram. This is the part of the partogram that we are going to look at. We are going to count down start will be from the latent phase. Okay, there is an alert line and the action line. This is the new type that is added in the WHO type of the partogram. Okay, and we are going to monitor the fetal heart rate every 1 hour, and also liquor, and if there is a liquor leaking or the patient is having any molding, that is also we have to consider. Next, how many contractions per 10 minutes and how many oxytocin drops that you have given, any other drugs or the IV pulsations that you have given, BP monitoring and the pulse monitoring, temperature, urine protein, and also these values also considered in the new type of the partogram. New type of the partogram that you have to remember, active phase consisting of the alert and also the action phase. All right. Next, moving on to the normal vaginal birth. How the normal vaginal birth will be occurring. Remember, with the mnemonic of the every decent female employee have the rest extremely late. She get the rest like extremely late. So every means this is the engagement. Okay, baby head is already engaged in the pelvis. Next, DC, descent, or you can also say this as a descent. Next, female, F for female, this is the flex of head. Head is flexed. And how it is going to rotate? It is going to rotate internally. Internal rotation. All right. Next, E for employee, it has to be extend now. It has to be extend. And next, re for R for restitution. This is the restitution. And another E is for external rotation. External rotation. And L for lateral flexion. L for lateral flexion. Let's see one by one. So before engagement, the engagement into the pelvis. Okay. After that, there is a flexion and the descent coming more downward, and internal rotation. And after the completing this rotation, there is a early extension, complete extension, restitution, and anterior shoulder delivery on the lateral flexion. So this is the normal delivery of the baby positions. All right. Let's see the labor. So one by one point, labor points that you have to understand. So labor is divided into the two types. One is the latent and other one is the active type. So latent type is around 4 centimeters. We will be considering less than 4 centimeters is latent phase, and If it is more than or equal to 4 centimeters to 10 centimeters, the complete dilatation is going to be the active phase. Okay. And if there is a defect, normally what happens? The normally in the patients of the primaries, it is going to be less than 20 hours. Okay. It is less than 24 hours. Multipara, which is the history of the multipara means there is a pregnancy. This is around 14 hours. Okay. Previous delivery. And this dilatation of the active, if the again this is divided as a primary and the multi. Okay, multi which will be having very fast less than 1.5 centimeters per hour, and the primary is having very late 1.2 centimeters per hour. 1.2 centimeters per hour we are going to see. All right, next, another problems if it is a prolonged phase of the latent. So if ever it is a more than 20 hours to the primary, if ever more than 14 hours to the multi, same from the normal, we are just differentiating. We have to give the rest. Okay, we have to give for the rest and check the pelvic examination, detailed pelvic exam. And if ever you find the CPD, then you can go for the LSCS. If ever the LSCS can be done for this patient, or rest. Sometimes after 1 to 2 hours also there could be dilatation. Next, protracted pelvis, protracted active pelvis. So what is mean by the protracted active pelvis? For example, less than 1 centimeter per hour. Only it is taking very long, 1.2 or the 1.5, but it is only 1 centimeters. Okay. Next, 1 centimeters with the fetal head is not descent. Still it is not descent. So then you have to do the per vaginal examination and also per abdominal examination. Per vaginal and the per abdominal. And if you see the contractions is hypotonic, that means decreased contractions, then you have to go for the oxytocin for this patient. Okay, if it is normal, then wait and watch. In the per vaginal examination, if you find the CPT, then go for the C-section. So this is how protracted pelvis is treated, right? Next, arrest. So arrest of the active phase. If the baby and the mother is having the arrest on the active phase, that means almost more than 4 hours is happened. Still the dilatation has been not progressed. The dilatation is not progressed. Even after the rupture of membranes, still there is no progression of the dilatation. Then we have to go for the C-section, because once the rupture of membranes is happened, the baby can have the cord compression. So that's why we have to proceed for the C-section. Next, second stage. This is also known as a prolonged arrest. Prolonged arrest. If you see the nulliparous or the primary more than 3 hours, or the multiparous mother is more than 2 hours. Okay, if they are having these stages, the second stage, if it is still not progressing, no change from these phases, then also the treatment is LSCS, that we have to proceed for the baby. Okay, so this is how we are going to consider the different types of the phases. Next, last but not the least, this is the third stage. In the third stage, mostly it is a placenta delivery only. So the placenta delivery won't be late, because if it is a late, we have to think about the PPH, or the patient is in the any other distress, or the amniotic fluid depression, or any other condition. We have to rule out. And here we have to follow the criteria of the AMTCL. So this is the criteria. They have said the 4 types. Okay, they have said there should be 4 types. One is you have to give the injection oxytocin within 1 minute of the delivery of the baby. Once the baby is delivered, you have to give oxytocin IM. Intramuscular has to be given immediately. And delay the cord clamp. Delay the cord clamp to prevent the anemia. To prevent the anemia. Okay, even with the HIV patients also we can go for the delay cord clamping. Next, controlled traction. Controlled cord traction with the suprapubic hand. On the suprapubic hand you have to place. Okay, this should not be the massage. It is the suprapubic hand that you have to press against the pelvis. Next, assess the tone. Assess the uterine tone. Because if the tone is still active, there is a chance of the PPH. This has to be criteria that has to be followed whenever we are doing the cord clamping. Okay, next, how we are going to proceed? It should be clean cord. It should be clean clamp. Okay, and also clean stump, clean surface, and also clean hands of the examiner. So these clean criteria should be followed. Okay, so this is the most important part that you have to remember. Next, after this we will be proceeding of the different conditions. Okay, let's start with the hypertension. So hypertension, remember that different types of the conditions that is seen with this pregnancy, they are all conditions can be occurred in the patients. So first and foremost important one is the hypertension. Why this hypertension is seen, especially who is a female with the pregnancy? And apart from that, there is an increased age or even the extreme decreased age. Early pregnancy also can cause. And all the females with the priming due to the early exposure of the first time exposure of the paternal genes, and also genetics from the mother or from the maternal mother or the paternal mother. This can also happen because the paternal genes from the husband side, it could be coming from her mother also. That can be also seen. And if ever the mother is having the twins pregnancy, or she is suffering from the diabetes mellitus, or uteroplacental insufficiency can be cause, or molar pregnancy, Rh negative pregnancy, or any other conditions such as smoking or the obesity can also dispose to this hypertension. And hypertension is divided into the gestational hypertension, and other one is the chronic hypertension. A chronic hypertension, and we also have the pre-eclampsia. We also have the eclampsia. Okay, also eclampsia. All these conditions that has been asked. What are the definitions for this? Gestational hypertension is more than or equal to 20 weeks. Okay, the patient is presented with more than 140 by 90 mmHg of the BP and no proteinuria. No proteinuria. This is the gestational type. Chronic hypertension, she is the pre-gestational. Okay, she is already a hypertensive patient. Okay, and without the no proteinuria, she is having from the before only. That is what the chronic hypertension. Preeclampsia more than 20 weeks. Either it could be more than 140 by 90 or more than 160 by 110 mmHg with proteinuria. This should be proteinuria for this patient presentation. And eclampsia is patient is hypertensive, any hypertension it could be, with the generalized tonic-clonic seizure of one episode. Then only we consider this as a eclampsia patient. Then only we consider this patient as a eclampsia, right? So this is how we are going to differentiate. Next, coming to the patients, how can we differentiate from the mild and moderate? Mild and moderate and severe. And there is also a new definition. There is a impending eclampsia. Impending. What are these impending signs? So mild eclampsia, there is only 140 by 90 mmHg of the BP. Fortunately, there is no proteinuria. Okay? Fortunately, there is no proteinuria. And the moderate and severe is follows this way: more than 140 to 90 or more than 160 by 110 mmHg, All right, and along with that, the patient is having the proteinuria, right upper quadrant pain. Okay, LFT is deranged more than 2 times the normal. Serum creatinine is raised. Serum creatinine is raised. All this will be considered as a moderate to severe type. Impending eclampsia, the patient is having the symptoms of the headache, right upper quadrant pain, and the visual field defects. Visual field defects. Okay, these are the impending eclampsia chances that the patient might go into the shock. And how we are going to start the treatment. So the treatment is most important here. Why the pathology is causing here. So there is a decreased placenta proliferation. There is a decreased placenta vascular proliferation. Okay, so this is going to cause this condition most commonly. So if there is a decreased placenta vascular proliferation, what happens? There is a high chance it can progress the ischemia, and if it is progress, it can produce the other agents to have the neovascularization. Neovascularization. So that's why the patient is having this condition. So how can we treat? Most of the times we are going to prefer the safe drugs such as alpha methyl-dopa. This is the best drug that we can give for this patient, most safest. And second one is the IV labetalol, but it is contraindicated in the patients of the asthma. Okay, and we can also go for the IV hydralazine can be given, and IV sodium nitroprusside. This is contraindicated as it consisting of the cyanide poisoning, but we can save as an alternative one. And also oral nicardipine. These are the drugs that we can give for the patients safe. Okay, how can we prevent? Prevent is done if there is a patient with a chronic hypertension, or if the patient is suffering from the APLA syndrome or any metabolic syndrome. We can start the patient on the aspirin. Okay, around 20 weeks we can start. The dosage will be 75 mg. Even in the diabetes mellitus twin pregnancies, we can start the aspirin. Okay, we can start the patient on the aspirin. This drug can be given as a prevention. And other than that, we can also add the calcium. Sometimes what happens? So the patient who is taking the calcium also will be low calcium also can cause. So we can supply the calcium supplements also for this patient, right? We can do this also. And apart from that, how the management has to be done for this patient. So if ever the patient is presented with the eclampsia, first and foremost is IV and IM MgSO4 has to be given for the patient. IV MgSO4 has to be given. Why I am telling the IV and IM? So there is a criteria, that is the Pritchard's regimen. Pritchard's regimen will tell us 10 mg has to be given to sides of the buttocks. This is the IM dose, followed by 4 mg IV has to be given for the patient as an immediate treatment. And this MgSO4 is going to prevent and also treat the GTCS, and also it gives a neuroprotection. All these best ways are seen with this condition. Contraindication: diuretics is not given, especially ACE inhibitors is not given, herb drugs is also not given. These drugs are not given for the patients. Next, how we are going to treat this patient. So if you see the patient is having the impending eclampsia, or the patient is having the HELP syndrome, patient is having the right upper quadrant severe pain, patient is had the eclampsia, all these condition we have to terminate the pregnancy. Terminate the pregnancy. Regardless of the gestation, we have to terminate this pregnancy. And what is the preferred route? Vaginal. Vaginal route is the preferred one that we have to follow. And if ever the patient is stable and no severe signs, then we can expect more than 34 to 36 weeks of the gestation. And here also probably vaginal delivery only. This is the preferred for the process of the patient who is diagnosed with a hypertension, right? So this is how we are going to proceed for this patient, and these are the some of the important points that you have to remember. Next, moving on to the diabetes mellitus. So the patient who is suffering from the diabetes mellitus, there is a criteria, two types. There is a type A and type non-A. Non-A is a overt, or we can say this is a pre-gestation. Before the patient pregnant only they had got this condition. Type A is presented with a gestational diabetes mellitus. This is presented at the time of the pregnancy only, exactly more than 24 weeks, because insulin resistance will be high at this point. And diabetes mellitus in the pregnancy of these patients, how we are going to follow this criteria. On the first visit, so when the patient is presented on the first visit, you have to do the DIPSI guidelines. What is this DIPSI guidelines? 75 grams of the glucose has to be given for the patient within the 5 minutes, followed by the glucose 2 hours. You have to check the patient levels that it has to be checked, and if it is more than 200, then it is considered as a diabetes mellitus, right? So this is how we are going to proceed for the patient. And if ever you see this patient is having only more than 140, this is the gestational diabetes. This is the pre-diabetes, pre-gestational diabetes. There is a differences. And reliable test is the HbA1c. Okay, reliable test is the HbA1c. If you see HbA1c more than 6.5%, so there is a 3% risk of anomalies, and if it is more than 9.5%, it is almost 10% risk. So the more the HbA1c, the more the risk of anomalies will be seen in the patient, will be seen in this patients. That is also one point that you have to remember. Next, another thing is that these congenital inflammations will be, congenital effects will be seen in the mother, right? So why these congenital effects will be seen? So the pre-diabetes mellitus, it produces the glucose. The glucose is glucotoxic. Okay, glucotoxic. So organogenesis will be disturbed in this patient. Organogenesis is increased disturbed in this patients. So that is why there is a organogenesis defects. So what is the first organogenesis? The most common you are going to see in this patient is the cardiovascular anomalies, and in the cardiovascular the most common will be VSD, most specific TGA, transposition of great artery, and clinically you are going to see hypertrophic obstructive cardiomyopathy, followed by the CNS. Mothers can have the anencephaly to the babies, and the specific one that is the caudal regression syndrome. Caudal regression syndrome. And the other thing is the macrosomia. Macrosomia. Why the macrosomia? Because of increased insulin. Because of increased insulin. But I said insulin cannot cross the placenta barrier, right? So how this insulin is going to affect? This is the fetal insulin. This is the fetal insulin. That is the one which plays the role for the macrosomia. More than or equal to 4 kgs. And the route of delivery is always vaginal. Is always vaginal. Only if it is more than 5 kgs, then we have to think about the LSCS of the patient. Then only we have to think about the LSCS. And the other fetal complications, we have the baby can have neonatal hypoglycemia. Neonatal hypoglycemia is seen in these patients, and decreased calcium, decreased magnesium, and increased RBC, that means increased hemoglobin. And if this is increased, hemolysis can happen. So as the bilirubin can rise in this patient. Okay, so decreased calcium, hypoglycemia. So the baby on the presentation can have the seizures also seen in these patients, right? Respiratory distress syndrome. Why respiratory distress syndrome? due to decreased surfactant production, because again insulin is a very toxic to the surfactant, so surfactant will be decreased in this patient. So these are the complications that is commonly seen with these patients, okay, of the pregnancy. Then how we are going to treat this gestational diabetes mellitus? If the patient is the gestational diabetes mellitus, we are going to again divide this as a A1 and the A2. A1 is a dietary, A2 is the medications. Okay, A2 is the medications. So at the time when the mother is presented with the 24 weeks of the gestation with a diagnosis of the GDM, so how we are going to treat these patients? So first and foremost, we are going to tell the mother for the dietary management. Okay, dietary management. And after 2 weeks on the next age in next gestational visit, we are going to check again OGTT has to be done for this patient, and if the OGTT is more than 200 mg, okay, if the OGTT is 200 mg and it is not controlled, then we have to go for the therapy, and the best therapy is the insulin subcutaneous has to be given for the mother. Any other agents can be given, yes, metformin can be given, and also glyburide can also be given for this patient. And how about the delivery? The patients of the GDM, they will be having the stability. Okay, the GDM can be go until 37 weeks. It can be go until 37 weeks. So as a pre-gestational diabetes mellitus also, 37 to 39 weeks. If there is no complications, we can proceed for this until this period. We can go for the delivery, right? So this is how we are going to treat for the patients of the diabetes mellitus, and these are the important points that has been asked in the previous examinations. Next, moving on to the twins conditions, we have the different types of the twins that you can see here. Okay, before that we have to know about the dizygotic and the monozygotic. Okay, dizygotic and the monozygotic, mostly the difference will be, this is the most common which will be seen, the dizygotics, and they are associated with the dichorionic and diamniotic, and the monozygotics which will be mostly associated with the IVF patients, and here they will be presented as a monochorionic and the diamniotic patients will be seen, and here the sex is different. It could be girl and it could be boy, the both are different, and here the sex will be same. It could be girl girl or boy boy, so the same gender will be seen, so that same HLA will be seen, but the difference is fingerprints will be different. Fingerprints will be different of this baby, and here everything will be different. HLA is different, and so as the fingerprints also different for these babies. So the difference between the dizygotic and the monozygotic, and the most common is the dizygotic patients that we are going to see. Okay, and how we are going to differentiate when this is going to, the presentation will be presented in the separately. So monochorionic monoamniotic patients, here you can see, so this is the monochorionic monoamniotic. So outside there is only one chorion, and inside also there is no only one amniotic. And when this is going to be presented, so this will be presented if there is a division less than 9 to 12 days. So this is the presentation the babies will be having. Okay, this is how they are going to have. Next, dichorionic diamniotic. So dichorionic diamniotic, so these they will be having at the less than 4 days only, less than 4 days, and this is the best prognosis that we are going to get, and this is the worst prognosis we can expect. Dichorionic diamniotic, the separate placenta, this is also same, again less than 4 days, and here also best prognosis we are going to see. And monochorionic monoamniotic, so one layer and there is a two, right? Two will be seen here. This is around, the monochorionic monodiamniotic is around 4 to 8 days. 4 to 8 days this will be seen. Okay, less than 4 days DADC, and 8 days MADA, MCDA, and MCMA, that is around more than 12 weeks, 12 days. Even if it is more than 12 days also, there will be conjoined twins that patients will be presented. Conjoined twins will be seen in these patients, right? So when it is comes to the twins, what we discussed guys, so they are signs that you have to remember. Twin sign. twin peak sign. So twin peak sign, this is seen in the patients of the dichorionic diamniotic patients. Okay, why? This twin peak sign is the thick layers. Thick layers. How many layers we have? Four layers. Four layers, right? So these four layers will look like very thick on the ultrasound of the patients. Okay, that's why it is going to look like that. Next, there is another sign. So this is the T sign. This is seen in the monochorionic diamniotic. Only the two layers is present here. So there is a thin layer which can be visible on the ultrasound. These both are present on the ultrasound, guys, because of these two layers. Next, we have the cord entanglement. So cord entanglement. So if the two babies in one womb with one amniotic, obviously they can have this. So monochorionic, monoamniotic, the patient can develop the cord entanglement. This is seen with this condition. And conjoint twins. Coming to the conjoint twins. Okay, mostly we will be having the paraphagus. Paraphagus means it is at the abdomen region. This is at the abdomen region, and this is also most common with the monochorionic monoamnion type. Conjoint twins will be seen. Okay, apart from this, we have the different types of the complications which will be seen in these patients. For example, the patients who is suffering from this, there will be a twin transfusion syndrome. There is a twin transfusion syndrome. So what happens in the twin transfusion syndrome? So there is a vascular abnormality. There is a vascular abnormality which is present in this babies. Okay, there is a donor twin and there is a recipient. So one brother is sending the whatever he have, he is sending to the other brother. So the donor is sending everything to the recipient. So obviously he will be having the anemia, and this baby is having the polycythemia, right? And anemia means oligohydramnios, and here polyhydramnios. Polyhydramnios is seen in this patient. So this patient is having the renal abnormalities which can be developed in this patient. More and more blood is coming, it is going to cause the viscosity. So this patient can have the thrombosis, right? Thrombosis is seen. And heart failure, both patients can have the heart failure, and both patients can have the hydrops. Okay, hydrops is seen. And in severe cases there can be death also for the babies, right? So what we can do for this patient treatment, if it is less than 20, more than 28 weeks termination of the pregnancy and deliver, whoever is alive, we can have the baby. But if it is less than 28 weeks, we have to do the ablation. What I said earlier, there is a problem here in the vascular abnormality. We can ablate that. That can be also done for this patient. And next one, there is a next type that can be seen. This is known as a trap. So again, here also arterial abnormality which will be seen in this patient. In this arterial abnormality, one baby, one twin will be dead and other twin is alive. Other twin is alive. So this is what's seen in the trap type of the patient. And next we also have the other syndrome which will be also associated with the twins only, and here there is a polyhydramnios is not seen, and same as the oligohydramnios is not seen. So this patients is a mild type of the twin transfusion syndrome. And twin transfusion syndrome has a separate staging. So this is staging is known as a Quintaro staging, and this is important for the INICT and the NEET PG but not asked in the Fmge examination. Okay, so this is how we have to differentiate about these things. And when it is comes to the patients of these conditions, how we are going to deliver. So coming to the delivery of these patients, it depends on the presentation. If the first twin, let's say that the first twin is presented as a cephalic, so better to go for the vaginal only. Okay, better to go for the vaginal. And if the second baby, second twin, if she presented as a breech, then you can go for the breech assisted delivery. Breech assisted. Again, if the second twin is in the transverse line, you can go for the internal podalic version. Internal podalic version can be gone. But Sometimes the internal podalic version is not done if there is a contraindicated in the history of the LSCS patients. Okay, for these patients we are not going to treat. So this is how we are going to treat the patient. Okay, but if the first twin itself having the breach or the transverse line, then we better go for the cesarean section only for these patients. Average, we can at least go for the 38 weeks of the age of gestation plus 6 days for the delivery. For the delivery of the babies. Okay. Next, moving on to the RH incompatibility. So RH incompatibility we are going to see here. So RH incompatibility means the mother is having the RH negative. The mother is having the RH negative. For example, she married the husband who is consisting of the RH positive. So there is a pretty much chances the baby can have the 50% from the mother, 50% from the father. What if the baby or the fetus is having the RH positive? So this is what the RH negative pregnancy is going to bring the complications for us. Okay, this is how we are going to, we have to differentiate. Okay, let's see how the patients will be having. So first and foremost, in the first antenatal visit, you have to check for the indirect Coombs test. Indirect Coombs test. So in the indirect Coombs test, if you see it is positive, is it negative? If it is a positive, it is a RH isoimmunized pregnancy. And if it is RH negative, this is a RH non-immunized pregnancy. Non-immunized pregnancy. So positive means that the baby must be having the RH positive from the father. Then what we can do for this patient? Let's say we have already confirmed this and repeat it after at the 28 weeks. If it is negative, repeat it after 28 weeks if it is negative. And if you still feel it is negative only, okay, ICT is still negative for this patient, so what we can do is RH prophylaxis has to be given. So that is anti-D prophylaxis that we are going to give. How much is the dosage? 300 micrograms that we are going to give for this patient around 39 weeks, because this is a negative. Still we don't know there is a risk or not for this baby. Okay, and after the baby is delivered, let's say that the baby is delivered, and if the baby has to be tested positive for the direct Coombs test, the baby has to test it for the direct Coombs test. Let's say this is also negative for the baby. Then we have to go for the postpartum. Then we have to go for the postpartum anti-D for the mother. Okay, this is has to be given for the patients. And most of the conditions, anti-D is given for the all the RH negative pregnancies, such as it could be abortions, or it could be previa patients, or also abruptio patients, even some MTP of the second trimester. Also we have to proceed for the RHD negative prophylaxis that has to be given for these patients. Okay, let's say as we discussed, this is a positive pregnancy, right? This is the RH positive and also ICT positive patients. Okay, so what is the next steps that we have to look for? We have to look for the antibody titers. If the antibody titers is more than 1.16, then this is the likely the patient is having the problem. Then we have to go for the MCA Doppler of the fetus. MCA Doppler of the fetus that we have to proceed. And here if you see more than 1.5 centimeters, so this is likely to be anemia chances of the baby. Baby is having the anemia chances. And what we can do here is the Corday synthesis. Corday synthesis. So this Corday synthesis is actually going to test for the baby's blood from the directly umbilical vein. This is looking at the umbilical vein. And the Corday synthesis is going to test whether the baby hematocrit is more than 30 or the hematocrit is less than 30. If the hematocrit is more than 30, yes, this is normal. We have to wait and watch. likely at the 38 weeks you can go for the vaginal delivery for this baby, and MCA Doppler has to be done for this patient, right? If the hematocrit is less than 30, on the ultrasound, if you see the hydrops fetalis, okay, if you see any other complications also, termination of the pregnancy has to be done for this patient, okay. And even if it is a baby is less than 35 weeks of the gestation, 35 weeks age of the gestation, wait and watch, wait and watch. And in some severe cases, what we can go is the intrauterine blood transfusion, and also the lungs is not mature, right? Steroid therapy has to be given. This is done if it is more than 35 age of week of gestation, and also hydrophytolis, any complications, termination of the pregnancy has to be done. So this is the criteria that we follow for these patients who is suffering. And as I said, hydrops fetalis means anasarca in the baby, and this is seen in the two types. One is the immune type, that is the Rh negative pregnancy, and it could be seen with the non-immune also. For example, cardiac disease, the patient is suffering from the cardiac disease, twin twin transfusion syndrome, and also viruses such as parvovirus and also syphilis. This question is also asked. So these are the hydrophytalis. Next, moving on to the antepartum hemorrhage. Okay, we have here antepartum hemorrhage. So the first one is the vasa previa. This is the vasa previa patients. So the patients with the vasa previa, this is a patient who is presented with the no history of the warning bleeding. She doesn't know that she had the warning bleed before. She is the first time who is presented with the bleeding. Okay, first time presented with the bleeding, and this is the painless, and you started to doing the examination. On that, fetal heart rate is bradycardia. It is showing the bradycardia. So the blood which is bleeding from the vagina, this is the fetal blood. This is the fetal blood. Why this causes happened? The most common cause is the velamentous insertion. Just before we discussed, this is the velamentous cord insertion can cause this condition. So the patient is having the fetal blood loss and the fetal bradycardia is seen. So these fetal bradycardia can cause the distress in the patients. So that's why immediately the treatment for this patient is the emergency cesarean section has to be done for this patient. Next condition, that is the abruptio placenta. Okay, this is the abruptio placenta. So in the patients of the abruptio placenta, how they are going to present it? Let's say they're having the history of the most commonly trauma, or the patient is having some drug induced smoking, folic acid deficiency. These conditions will be seen, and there will be presentation of the third trimester bleeding. Third trimester bleeding, this bleeding is painful bleeding. Let's say this bleeding is the painful bleeding, and this painful bleeding which will be associated with the pain abdomen also, pain abdomen. And on the ultrasound you are going to see there is a behind the blood behind the placenta. So there is a either the type of concealed, here you can see this is what the concealed type or the revealing type. So sometimes it could be revealing or it could be concealed. So what is the risk if there is a concealed type? So because it can increase the DIC, the disseminated the coagulation disorder can be seen. Why? Because of the thromboplastin. The thromboplastin which is released from this blood which is behind the placenta can trigger the DIC in this patient. Okay, and if ever the patient vitals, whether it is a fetal or the mother, if it is a stable, okay, then we have to go for the vaginal delivery. Okay, if it is more than 34 weeks of gestation. If the vitals are deranged, same either the fetus or the mother, what we have to go, regardless of the patient age of gestation, we can go for the induction of the labor. Induction of the labor has to be started. Okay, induction of the labor has to be started, and if it is deteriorated, then we can go for the LSCS of the patient. And if the baby is stillborn or the intrauterine death, vitals is stable, let's say vitals is stable, for this patient we have to go for the vaginal only. Still we have to go for the vaginal, just depends on the patient vitals, and that we have to see. Let's say that the patient vitals is stable, okay, concealed, still it is a concealed, but the age of gestation is 34 weeks only. Then we have to expectant, admit the patient, look after for the signs of the DIC. If there is a DIC, then again we have to go for the cesarean section of this patient. Okay, next, moving on to the placenta previa. So this is a condition that is associated with the placenta previa. So patients who is having the placenta previa, there are the four types: type 1, type 2, type 3, type 4. Type 1 is a low lying, type 2 is a marginal, this is the incomplete, and this is a complete. Okay, this is the complete. Which is more danger? The more danger is the marginal. Don't think it is a complete or the incomplete. Actually the type 2 is more danger. So the patients with the previa, so there will be a history of previous, there is a history of the previous placenta previa history. This is the very strongest risk factor that the patient will be having. And there is a warning sign. Warning signs means there is a warning bleeding that the patient is actually having this condition, but she doesn't know because this is a painless. This is a painless bleeding. Painless bleeding that is going to be presented. Okay, and when you are checking the examination, the uterus is soft and non-tender. Uterus is soft and the non-tender. Okay, so this is how the patient will be presenting with the placenta previa. And again you have to look after for the age of gestation. Okay, if it is more than 34 weeks, if the patient is having the more than 34 weeks and patient vitals is stable, patient vitals is stable, then we can go for the expectant management. That means we can wait and watch, because till 34 weeks the lungs has to be matured for this baby. Okay, less than 34 weeks but the vitals are unstable, immediate LSCS has to be done for this patient. Immediate LSCS has to be done. Less than 34 weeks, less than 34 weeks, but vitals are stable. Then we have to follow the McAfee regimen. This is the McAfee regimen. What is this McAfee-Johnson regimen? So the McAfee-Johnson regimen, we will be following the patient with the admission, admit the patient, and the monitor the patient with the help of the biophysical profile, NST, okay, antenatal care. Okay, if there is a warning sign, we also going to look after, and after the time 39 weeks of the gestation plus or minus 6 days, we can go for the LSCS for this patient. So this is how we are going to follow up. Depends on the vitals, you have to make sure that the patient has to be taken care. And the another point is per vaginal examination, per speculum examination is contraindicated, here. What about the TVS? TVS is the investigation of the choice, it is not a contraindication. Okay, so the per vaginal examination and the per speculum examination is contraindication for these patients. Next, last APH, this is the placenta accreta syndrome. Okay, what is the placenta accreta syndrome? Here you can see the accreta patients is the most common. Overall accreta will be the most common. Okay, so the patients with the accreta condition, there will be suffering from the, it is involving of the myometrium. This is involving of the myometrium. Okay, and in creta it is going to involve the complete myometrium, and the per creta, this is involves the serosa also, and sometimes it can also invade the bladder. It can invade the bladder also. So this is the condition placenta accreta syndrome. Placenta accreta syndrome. And most commonly the patient will be having the history of the previa, with LSCS, with the LSCS and the history of the previa. So this is a classical presentation of the placenta accreta syndrome. Okay, what is the defect? So the defect is in the placenta we have the layer that is known as a Nita Butch layer, but this layer is absent in this patient, so that's why the barrier is damaged and it is invading into the endometrium of the patients. And what is the treatment of the choice for this patient? If the patient is stable, you can go for the vaginal delivery, and post vaginal delivery, if the family is complete, let's say the patient is having family is complete, then we have to go for the hysterectomy. Don't remove the placenta. Okay, after the remove is contraindicated of the placenta. You should not be removing the placenta. It could be catastrophic. Go for, if it is a family is complete, then go for the hysterectomy of the patient. That is the best treatment. Even the LSCS also. Even after the LSCS also, you should not be removing the placenta. Just if the patient is having the complete family, then we can go for the hysterectomy. But if the family is incomplete, just close the patient. Again, placenta should not be removed. Placenta should not be removed. Contraindicated. Okay, here also it is a contraindicated. Okay, most of the times we will be proceeding with the hysterectomy only. So this is the basics about the APH, guys. Next, moving on to the next condition that we will be discussing here is the postpartum hemorrhage. So postpartum hemorrhage is divided into the two types. One is the early postpartum hemorrhage, less than 24 hours, and late postpartum hemorrhage, more than 24 hours. This is the one criteria that we can divide. And other one is the more than 500 ml in the vaginal, okay, or more than 1000 ml in the LSCS patients. If it is having, then we have to consider this as a postpartum hemorrhage. And overall, the most common is uterine atony. This is the uterine atony. And in the uterine atony, the common cause is the tone. This is the most common, or it could be tissue, retained tissue. That can also be the cause, right? So this is the most common cause for the uterine atony. What we have to do for these patients? So mostly what we have to do, we have to resuscitate, because bleeding has to be controlled. At the same time, patient should not be deteriorated. So resuscitation is important for these patients. And how you are going to resuscitation patients? Same, A, B, C. Circulation, breathing, airway has to be stabilized. Following that, what we can do is the massage the uterus. Okay, this is the bimanual massage has to be stopped. Sometimes this bimanual massage can control the bleeding. Again, bimanual massage is not controlled. What we can do for these patients? We have to proceed for the drugs. We have to proceed to give the drugs. What are the drugs can be given? The best drug that we can give is the oxytocin. Oxytocin can be given for this patient because the tone is not working. Trying to give the oxytocin because it will increase the tone. And also carboprost. Carboprost is given, but the carboprost is contraindicated in the asthma patients. And mifepristone can be given for this patient, and vaginally can be given, and also methergine can be given. Methergine can be also given. Dinoproston is not given, guys. Remember that. Okay, these drugs can be given. Unfortunately, still it is not controlling. Even after the drugs also it is not controlling. So here we will be following the Bakri balloon catheter. Okay, Bakri balloon catheter. So Bakri balloon catheter, almost 500 ml of the fluid is filled, and this is the Bakri balloon catheter. Here you can see. So this is the Bakri balloon catheter. We will be inside the uterus. We will be filling it. It can sometimes can stop the bleeding. Even this is also not stopping. What we can do? We can go for the B-Lynch sutures. So, okay, B-Lynch sutures. For example, this is the uterus. You are going to stitch the uterus tightly so that the bleeding can be stopped. Still, unfortunately, still the patient is having the bleeding. So this time we have to go for the uterine artery ligation. Uterine artery ligation. Arterial embolization should be done. Still here also it is not controlling. Then we can go for internal iliac artery ligation. Internal iliac artery ligation. And before, the ovary arteries can also be ligated, but internal iliac artery has to be ligated. And still not controlled. Still not controlling. Still not controlled. What we can go for is the subtotal hysterectomy. Subtotal hysterectomy. Okay, most of the times it is going to stop. If still it is not completed, then we have to do the pelvic pressure pack. Pelvic pressure pack has to be put for the patients. So this is a very serious condition, should not be ignored anytime. Okay, this has to be, should not be ignored. Next, moving on to the next condition. This is also another important condition that has been asked in the examination, guys. And this condition is uterine inversion. Okay, this is the condition of the uterine inversion. So uterine inversion, here you can see this is the uterus part, and sorry, this is the uterus part, this is the placenta part. So it is completely came out of the patient body. So what happens in this patient's uterine inversion? It is a very serious condition, guys, because immediately they can have the shock. Okay, so immediately the patient having the BP fluctuation, and also cardiac output is decreased. Sorry, so the patient BP is decreased, cardiac output is decreased because some of the internal organ is came out. It can trigger the other organs also. The perfusion can be also decreased to this. What is this condition? This is the shock. So the neurogenic shock is triggered in these patients. This is the early. Okay, and after the time, what happens? There is a hemorrhage. Uncontrolled, untraced bleeding will be seen, and this can cause the hypovolemia in the patients. So already the patient is in the shock. This can cause the hypovolemia shock or the hemorrhagic shock in the patients, and this can lead to the cause of death. Cause of death is patients. Per abdomen, there is a depression because the uterus is came out at the suprapubic position, right? And the per vaginal, you are going to see the globular mass. There is a globular mass like this you are going to observe, and the treatment for this patient is should not be given the oxytocin. Oxytocin is contraindicated because oxytocin can increase the tone and more bleeding can happen, right? So oxytocin has to be stopped for this patient. And we have the Johnson technique. So what is this Johnson technique? They will be insert the uterus manually back to, okay, manually insert the uterus back. Okay, and if it is not controlled, then we have to go for the laparotomy. And abdominal surgery has to be done for this patient, and then we have to go for the hysterectomy. Even if it is not controlled, hysterectomy has to be stopped for this patient. Okay, but if you can, in the Johnson, oxytocin has to be stopped, but start the patient on the tocolytic. So that the contractions will be stopped in this patient. If you can put this like insert the manually is done, then what you can do is better go for the stop the tocolytics. Stop. Then start the oxytocin inside the uterus once you keep, but before you keep you should not do this also. Okay, so stop the tocolytic and start the oxytocin for this patient. Okay, so this is the uterine inversion. Next condition, this is the retained placenta. And retained placenta is rare and the late cause, more than 24 hours to 1 week the bleeding will be seen. And uterine hematoma, another type. Uterine hematoma is most commonly seen with the forceps injury or the other instruments injury that can be seen in these patients. Okay, and most common site will be ulval hematoma will be seen in this patient, the bulging mass which will be seen. And other one is a uterine rupture. So uterine rupture patients, obviously there is a history of the LSCS patients, previous history of the LSCS. So suddenly if there is a transverse line, so this having the more tension in the abdomen, so the fetal bradycardia will be seen. Okay, fetal bradycardia is seen. Suddenly the maternal vitals will be disturbed. Per abdomen, you are going to feel the superiorly fetal parts We can't feel because we have to feel the fundus. But here fetal parts is visible. Okay, fetal parts is visible, and there is a discharge per vaginal discharge will be seen, and the descent, for example, it is a +2, it will go back to -0 or the -2, so it will go back. So this is what the uterine rupture. And for this patient, how we are going to proceed? Laparotomy, and if the family is completed, then you can go for the hysterectomy. Hysterectomy has to be done for these patients. So these are the two conditions that can be asked in the examination, and recent INCT also focused on these types. Next, let's see some of the important points, just a small glimpse about the maneuvers. So we will be discussing here is the shoulder dystocia. Okay, shoulder dystocia is seen in the diabetes mothers most commonly, and also macrosomia patients. And when you consider this as a shoulder dystocia, more than 1 minute, the head is not delivered, then we consider this patient as a shoulder dystocia. Okay, and how we are going to proceed? First, call for the help. Okay, call for the help, and still we have to proceed for the vaginal delivery only. Call for the help, vaginal delivery, and first one has to be done, most common, and this is also known as a McRobert maneuver. McRobert maneuver is done for this patient. After the McRoberts maneuver, we are going to put the suprapubic pressure. We are going to put the suprapubic pressure, and even after that it is not done, then we will insert the hand inside the pelvis. This is known as a wood screws maneuver. This is known as a wood screw maneuver. Okay, after that we will be proceeding for the Gaskin maneuver. After that we will be proceeding for the Gaskin maneuver. Even this is also not done, then there is a Giovanelli maneuver. This is a Giovanelli maneuver, and further LSCS is done for this patient. These are the steps. So this is the McRobert. But when you are hyper extending and adducting, pushing towards the lateral side, there is a chance it can damage the nerve, and that nerve is meralgia paresthesia. You remember meralgia paresthesia? This is the lateral cutaneous nerve, right? And here you can see this is the other maneuver that has been performing in this patients, right? And this is the Gaskin's maneuver. Okay, arm delivery, and this is the Giovanelli maneuver. Giovanelli final maneuver. The patient will be on the 4 limbs. She has to be delivered. This is the Giovanelli maneuver. And when you are hyper extending of the baby, also baby can also have the damage, Erb's palsy, right? C4 C6 root damage, Erb's palsy also seen in this patients. So this is the one type of the maneuver that we are going to perform. Next, breach types. Breach types, here you can see this is the complete breach, this is the frank breach, and the footling breach. And one of the most important point about this is the which is the following is the most common. Most common will be the complete breach only, complete breach. And in the patients of these patients who is having the frank breach, and for these patients the maneuver that we perform is a Pinard's maneuver for the delivery. And the footling breach, there will be associated with the cord prolapse. This patient will be having the cord prolapse, and very severe condition for these patients. And the treatment is mostly we are going to proceed the 39 weeks of the gestation for the delivery, and breech assisted delivery we are going to perform for these patients. Breech assisted only we are going to perform. And for this patient we can go for the vaginal, and here also we can go for the vaginal. Due to the cord prolapse we can go for the LSCS. Through the vaginal, breech assisted position we have to follow for these patients. Okay, Pinard's maneuver. This is the Pinard's maneuver. Here going to press. This is the Pinard's maneuver. And here this is the another maneuver. This is the groin traction. Groin traction as the breech assisted delivery. And this is, here you can see this is the Burn Marshall type. So head and like this you are going to remove, Burn Marshall type. Okay, next another picture that you can see, this is the Prague's maneuver. This is the Prague's maneuver, and Prague's maneuver is the back side is on the posterior, right? Sacrum posterior, the back will be seen. In the burn marshal, the head will be on the posterior. The head will be on the posterior side. So these are the some of the maneuvers that you have to remember and can be asked in the examination, right? This is the overall obstetrics of the class, guys, and tomorrow we will be discussing of the gynecology. And if you have any doubts, please do text in the telegram group, and also please do join the telegram group if you want to avail the notes. And those who are new to this channel, please do subscribe and share with your friends. And if you do like the video, it will reach the more students and it will be helpful for the students, guys. And don't forget to subscribe and like the video and share with your friends. And until then, see you guys in the next video. Thank you, everyone.